Now, some of whom from gastric band to either sleeve or bypass. So the gastric band itself is not as invasive as the sleeve cases. So we have the band put on the patients, and we know that this was one of the first maybe procedures that we have done. So from band to sleeve versus sleeve to bypass, there are different levels of revision surgery. So I just want to point out, not all of them are as severe as the others. So if someone is going from band to sleeve, that's not as complicated or not complex as if they are going from sleeve to bypass. Is that true?
So it is a little bit more nuanced than that. For instance, the gastric band itself, although generally people view it as a completely reversible procedure because there is no cutting of the stomach or separation of the stomach from the intestine, the actual placement of the device itself does cause a significant amount of scar tissue, sometimes really altering the anatomy significantly. Not only that, but also the stomach where the band has been placed becomes much more thickened. So going back to do any surgery, whether it's a sleeve or a bypass, can be a very challenging procedure. On the other hand, when we're going from the sleeve to bypass, because the stomach has already been partitioned in part, it may actually sometimes be even an easier procedure than doing the gastric bypass originally, because the stomach is already small. Now, each case obviously is different because everybody will have a different amount of scar tissue and different amount of alteration of the anatomy after their primary procedure. I think it is probably better to understand that any type of revision procedure where we are going from to a different procedure that requires stapling and suturing is inherently a much more complicated procedure. And that can apply to band to bypass or sleeve to bypass itself.
So now, bariatric surgery is one of the most powerful tools to fight morbid obesity, and the outcome can be extremely good, and we have a really high success rate. With all these, the weight regain, complications, some results not being so satisfactory may be happening. So what are the most common reasons a patient might need another surgery, a revision surgery?
So there may be complications that occur after the first bariatric procedure. For instance, as I mentioned before, a person who's had gastric bypass could develop an ulcer at the junction between the stomach and the intestine, which may not be responsive to medical treatment. A person who's had a gastric bypass may develop a stricture, which is a narrowing at that connection. Or a person who's had a gastric sleeve may have developed heartburn that has become less responsive to medications requiring additional procedure. So these are things that can happen after bariatric surgery. But also there is the issue of inadequate weight loss, so that the patient has not really achieved the weight loss that we have hoped for them to achieve. Now, the procedure itself may have a role in this outcome, but the patient himself or herself also may have a role in this. So yes, we do surgeries, revision surgeries, to improve the outcome. For instance, we may go from the sleeve to gastric bypass, we may go from the band to sleeve or from band to gastric bypass, which are more complex procedures that may give the patient a better tool for them to lose weight. So in general, we do revision surgery either because the outcome has not been as satisfactory as we have wished in terms of weight loss, or because the patient may have developed symptoms related to some complications that can occur after bariatric surgery.
So revision surgeries are not offered lightly. So I know I read some of your notes, other surgeons' notes. We give not only different treatment options, but I see where we want patients to really follow through certain protocol before we take another surgery on them. And what's the way of evaluating these patients, whether or not they are a good candidate for a revision surgery?
So, as you correctly said in your introduction, these procedures should not be taken lightly, right? And certainly should not be the first line of treatment for whatever problem we are faced with, right? So, if a person has an ulcer, for instance, the first line of treatment would be medications. If a person has a stricture, there may be other less invasive procedures that can be done to take care of that. For instance, we can do something called endoscopic dilation, where we actually can go with an endoscope inside and use a balloon to stretch an area which has narrowed and is causing the patient problems. And similarly, if we are thinking about additional intervention because the person hasn't lost enough weight or because the person has regained substantial amount of weight afterwards, surgery should not be the first thing we are going to think about. We have to review the whole situation, right? We have to be able to understand why that person has not lost enough weight or why they are struggling with weight regain again, because the factors are multitude. It's not just a simple factor. So it's not a question of has this surgery failed the patient, right? We have to say, what was the role of the patient, their environment, their situations that could have contributed to this less than satisfactory outcome. So definitely revision surgery should be considered when appropriate, but it shouldn't be necessarily the first thing that we're going to jump into. We have to consider many other issues, and we have to also, especially when it comes to addressing weight regain, we have to look at the foundations. So if the person has really lost focus, right? And they're struggling. Well, what is to guarantee that that's not going to happen again, even with that second surgery, right? Are we going to go to a third surgery after that? So we have to address some foundational problems. So if, for instance, the person is struggling because emotionally they're having a lot of stress and they are looking into eating and consuming a lot of sugar to address that, that is not necessarily something that can be resolved by revision surgery by itself, right? We will need our nutritionists to be involved. We will need our psychologists to be involved. And we can address these issues. And we may still need to offer a revisional procedure, but at least we have some robust foundation, essentially, upon which we will have this second procedure.
So we have 134 patients. I was able to have a data validation with two of our resources who helped me with this project. I don't know if we can call this research or maybe it's some derivative of research, what we did, but it's a study, perhaps that's a better term to use. So out of 134 patients, we measure patients only with BMI higher than 39. So in 6 months, the average weight loss was 2.4%, I believe. So now there are some patients on the top with 10 or 12 of them who have the teens, 10, 12, 13, 14%. And then we have some patients on the bottom side, they gain weight. And then overall, the average, they are at 2.4%, maybe even 2.3. So what I have seen while going through and validating the data is, one is they may not be best administered by everyone. Now, I'm going to out you a little bit. So your wife actually is one of the weight loss physicians. She's board certified by Medicare, and her approach is different. She's not a surgeon, and I want to make sure that you guys don't have a fight tonight. So we are not going against what she's trying to do. She's a board certified medical weight management primary care.
Yes.
So, and her approach is different. She works with nutritionists when she's working with the patients. Patients do come back on a regular basis, and patients do their lab work. And if we don't see the results, she stops. At least that's what we have seen. But when it's not done by the board certified people, then the outcome can be very different. It's not something that you can just put the patient on and forget about them, and then they're going to be okay on their own. In some cases, you need to adjust the dose, right? If you haven't seen the patient, so it's not going to happen. But it was kind of surprising to see. In fact, one of the people who did the final data validation, she's a pre-med at UPenn, and she's like, is this real? And then she has full access to the EMR, and she sees no results. But then The buzz around these medications is huge. So it was an interesting study for us to see. Now we are about to finish the 12 months of the same group to see if they have a better outcome in 12 months. But when you see a lot of patients actually gaining weight, so you understand that this is not just something you can just put the patient on and forget about it. So this is one of the things that when I was talking to Dr. Irgau about this specific issue, in some cases, patients feel like they have this magical pill, and because now they're on it, they can be more free to eat more and without changing anything. And then all of a sudden, they gain weight. And this happens. So unfortunately. Now, we know that surgery always comes with its own stigma because I talk about my family every once in a while. My mom thinks we are cutting everyone's stomach. I'm like, well, not everyone. So this is patients with morbid obesity. And most of our average is about 47, BMI 47. And then we see patients with over 60. We see patients with high 30s, but averaging is about 46, 47. Now, these patients are struggling with life altogether, but the stigma of surgery itself is still out there. What would be your message for those hesitant about taking the next step for surgery?
That's again a great question, Kemal. So obesity is a major problem in the United States. In fact, by 2030, we expect almost 40% of Americans to suffer from significant obesity, enough that their body mass index is like 40 or higher. So those are serious health hazard. And sad truth is that only 1% of the patients that need to see a doctor, need to have surgery for weight loss, actually end up getting surgery. And a lot of that has to do with the hesitation, just because the word surgery attached to bariatric surgery. These surgeries, they are actually a medical treatment meant to treat a very serious medical problem. Mm-hmm. Yes, it does involve modifying a part of gastrointestinal tract, whether it is a patient feels satisfied with smaller portions of food, or helping modify the way the food gets digested so they don't absorb as much food, right? Or a combination of this. But it's in effect medical treatment for a medical problem. I would tell patients is that many of our patients in their 30s and their 40s, 50s, and 60s, when they come back and like after a few months of surgery, they say, "I wish I'd had this surgery done a year ago. I wish I'd had this surgery done 10 years ago when I started to face this problem, but I wish I'd known about it." And then that's what I want to let patients who are a little hesitant about surgery, talk to us. We'll help design the right program for you. I like to tell my patients is that like in that boxing ring, right? Fighting has a coach, right? Mm-hmm. So you are Rocky and you're fighting obesity. We as a team, we are your coaches, we are your life coaches. We are there to help you be successful. So bariatric surgery is only part of that treatment. The entire treatment is nutritionists we have, the psychologists we have, the support mechanisms we have after surgery. If you're struggling with weight loss, we are there to help support that. And we are your coaches for the rest of your life. So we would expect to see you, after a year after you've had surgery. So yes, you're hesitant, talk to us. Let us know why you're hesitant. And, and if you're not the right patient for surgery, then we can talk about medications as well. But, surgery, it's a great tool, a wonderful medical treatment in a sense to treat a medical problem.
So going back to bariatric and morbid obesity and our fight with morbid obesity. So the bariatric surgery triggers a great rapid weight loss. But maintaining this loss is, especially for the long term, can be challenging. So studies show 20 to 30% of the patients may regain some part of this weight loss again in the following 5 years. Mm-hmm. So the question is, what can we do? Why do some patients regain weight after initial losing so much post-surgery? What are the main reasons and what can we do for this?
Absolutely. So this is a very important topic, and we've touched upon it before, but it's important for us to revisit again. First, let's be very clear. Bariatric surgery is still the most effective treatment we have for morbid obesity, without question. And yes, even with this effective treatment, weight regain can happen. Now, it's important to qualify weight regain. We're talking about significant weight regain. Some weight regain may be very common. For instance, if you take somebody who is about 5 foot 5 inches in height, and they came to us when they were about 250 pounds. They wanted to lose 100 pounds. They have bariatric surgery, they have a sleeve gastrectomy a year and a half later. 2 years later, now they are 150 pounds. Perfect weight, perfect body mass index. They love it, right? But over some time, they can regain 10, 15, 20 pounds. Now, if they, in the long term, can maintain a weight of 170 pounds, they are still a success. They're not thin like they were at 150, but they still are very healthy. So that's not the type of weight regain we're talking about. We're talking about significant weight regain. So in our example, if that person was to regain weight so that now their weight is over 200 pounds, that is significant. And the question is, first of all, does it happen? Yes, right? Now, and that tells you that even with the most effective treatment we have, obesity is a very tough opponent, right? It is very challenging.
Definitely.
So you've asked, why does it happen? Well, there are a number of reasons. First of all, the small stomach that we create, for instance, after the sleeve gastrectomy, or the small connection that we create after gastric bypass, they can stretch to some extent. They will never go back to the original size, but the stomach can become, for instance, a little bit less resistance, more compliant, more accommodating, right? And that can lead perhaps to bigger portions. People can go back to old habits, slider foods, high calorie beverages, right? All things really that can lead to a gradual and slow increase in energy intake, in food intake, that will lead to weight gain. And of course, we cannot forget that obviously psychological challenges, particularly when people go through tough times, whether it's because they've had a loss in the family, they lost their job, they got divorced. These are huge, impactful stressors that they may run into the comfort of food very quickly. And very often, when I see patients that have regained significant weight after many years after bariatric surgery, invariably patients will have encountered a stress that has really pushed them into that direction.
Excuse me. Thank you, Dr. Ergau. So now my next question is the issue around the nutrition and the role of nutrition with weight maintenance. So what are the most common nutritional mistakes patients make after bariatric surgery?
Yeah. Well, one of them is to really skip their protein goals, for instance. We talk about how important protein intake is after bariatric surgery because all of us require a minimum amount of protein intake, right? Now, with bariatric surgery, you are diminishing the overall size of their meals, right? The volume of food they can eat is very, very small, right? So within that, they still have to maintain a certain amount of protein intake. So if they really don't watch their protein goals, that could be one of the mistakes that he could make. Going back to sugary beverages, empty calories, whether it's sodas, juices, or God forbid, alcohol, those are things really that are a major mistake. Grazing is another one, right? They cannot eat a big meal, but if they continually eat during the day, continually having something to bite and to munch through the day, which we call grazing, that also can result in a significant calorie intake that over the long term, obviously that can lead to a problem. So it is important for them to stick to what we teach them. In other words, to make sure that their eating is structured, eat in a structured way, in a planned way, rather than mindlessly, right? Secondly, they have to make sure they have adequate hydration, and also their protein intake always takes priority.
So the protein intake is important because, as you mentioned, it preserves lean muscle mass, which is critical for metabolic health. So now if you can elaborate this a little bit more, why protein is so important, for protein intake is so important.
So as you mentioned, it is related to preserving our lean mass beyond the fact that many functions in our cells are actually based on proteins that do the actual work. So there is structural protein and there is functional protein, which is really essential for our health. Now, if we don't have enough protein, we may lose lean body mass, which is fat-free mass, right? That we lose muscle. Well, if that happens, actually we may end up decreasing our basic metabolic rate, which is essentially the energy that we consume when we're doing nothing. So If somebody sits all day long, Kamal, they will still be consuming energy. It's called the basic metabolic rate, right? But that actually tends to go down if we lose lean mass. And if that goes down, it means that we're not spending energy, which means that whatever we're eating is going to be stored, right? And it's going to be stored as fat. And then there is also this reaction of the body that when lean body mass is lost, the body freaks out. It thinks this is a threat to our survival. So it instigates survival mechanisms for intake of energy. So hunger can increase suddenly. So paradoxically, when we're losing lean body mass, we end up actually regaining weight, but the weight that we regain can be fat. So we can have much more fat than we initially had proportionally if we get into that situation. So to avoid that, it is important for us to have adequate protein intake. Most people should be taking about 60 to 80 grams of protein daily. So that should be really the baseline. For some people, it may be more based on their height, but for most people, that would be really what we are looking for. So that's why this is important and why we emphasize on it so much. And then the other thing that is important also is that clearly when people eat protein, they tend to get fuller quickly. And that fullness actually tends to last longer as well. So they tend to graze and eat throughout the day much less if they're taking protein first.
Absolutely. So physical activity is one of the elements is non-negotiable for us. So physical activity is linked with improved weight loss maintenance in both surgical and non-surgical population. So how does regular exercise impact long-term weight maintenance after bariatric surgery?
So bariatric surgery will reset our metabolism, right? It will get our metabolism to be at a different level and respond differently. That's why we end up losing the weight. But for us to maintain the weight loss in the long term, we have to be physically active. This is very important. In fact, it is important to understand that when you exercise doesn't help you much in terms of losing weight. But what exercise does is it helps you to maintain that weight. Right? So in the long term, we want our patients to be physically active because it is so important and critical for maintaining weight. But there are other very important advantages of exercise. For instance, it's good for our mood, right? If you're stressed out and you feel like going for that piece of chocolate, right? Why not go to exercise, right? That will take care of the stress. But also on the flip side, you avoid going back into bad eating habits as well. So boosting your emotions in a positive way is another very important advantage of exercise as well.
Now we are going to go to our second topic, subtopic for today. That's going to be the smoking before and after surgery. So we know that smoking has well-documented negative effect on wound healing, increasing risk of surgical complications, including leaks and infections. And there are so many other issues that comes with smoking, and this is pre and post-surgery. There are so many different level of risk. So why is it important for patients to stop smoking before bariatric surgery, and what's the recommendation for them to stop smoking if they are a current smoker?
Well, smoking really increases the complication rate of the surgery. It's as simple as that, right? We want the surgery to go smoothly. We want the recovery to go smoothly. It's critically important, right? And smoking interferes with that, right? So as you correctly said, smoking interferes with the ability of the body to heal, right? So you can have leaks and infections. Healing, people think that the surgeon's sutures are making us heal, right? Actually, the surgeon's sutures just put the tissue, approximate the tissue together so that the healing occurs through nature. The body itself does the healing, right? It's not the sutures that we place. If it was just our sutures...
That's when it starts, actually.
That's right. So the sutures will place the tissues in close proximity, right? But the attachment of the tissues together so that healing occurs is a natural process, right? And that natural process is interfered with if the person is smoking, which means that any connections that we've made, any portions of the intestine that was divided will be at risk of not healing and therefore serious consequences afterwards. So smoking has those potential risks associated with it. there are problems with anesthesia, right? Your ability to recover from anesthesia, your ability to get rid of the breathing tube after anesthesia can be affected. Your ability to expand your lungs properly after anesthesia can be affected, and therefore you're at risk for pneumonia. Your ability to develop blood clots can increase if you are a smoker. So there are a host of reasons of why smoking must be stopped before bariatric surgery. And because bariatric surgery is never an emergency surgery, bariatric surgery took a stand on this and said, we do not want to encourage a behavior that can be modified that to continue before surgery and affect the outcome of the surgery. So most bariatric programs, including ours, actually require patients to stop smoking 6 to 8 weeks prior to surgery for that reason.
Yep. And what are the risks of returning to smoking after the surgery? Once everything is healed, that's fine, but now 3-4 months later,
Yeah.
they
Clearly, we're here focused on the implications of surgery on bariatric surgery, right? But there are 100 other reasons why smoking is a bad idea for a person's health, right? But just focusing on bariatric surgery, for instance, patients who have had gastric bypass can develop ulcers, particularly at the connection between the stomach and the intestine. And ulcers are bad news, Kemal. First of all, they are very painful. The pain from ulcers is just something that doesn't let you go. You cannot sleep, you cannot eat. It is really ruins your quality of life. And then the ulcers themselves that usually heal with medication will not heal if that person continues to smoke. And then there is another part to this story. Ulcers can be complicated by perforation. In other words, the ulcer can burst and let all the intestinal contents into the abdomen, creating something called peritonitis that can lead to very serious problems. Or, God forbid, the ulcer can lead to life-threatening bleeding. So a patient with an ulcer that bleeds can present to the emergency room with massive bleeding, throwing up bleeding, essentially, right? And those can be life-threatening. So because smoking is associated with that, it's very important that patients do not actually take on smoking again. Another problem is, for instance, heartburn. Heartburn gets actually a lot worse if a person is a smoker. And with the sleeve gastrectomy, heartburn is one potential consequence in some patients, and therefore smoking is going to make it worse. And of course, there are other pulmonary problems that can occur afterwards as well.
Sure. And one of the things that we also know, smoking does increase the risk of sleep apnea or severity of sleep apnea. And then that's one of the things that we try to take by having the CPAP or APAP machine. We are trying to actually control that situation. But if they keep smoking, other than digestive issues, there will be, as you said, pulmonary issues.
Absolutely.
It's just overall, it's not worth even trying. So now, lastly, we are going to discuss the alcohol use after surgery. Well, even before the surgery, we want people to stop smoking and drinking alcohol. On the alcohol, the issue is a little bit different. One is like smoking doesn't have much to do with the extra calories, but alcohol comes with way too much unnecessary calories. And our goal is to lose weight, and then we would be sabotaging our own process. Now, after the surgery, the digestive system's ability to process alcohol is altered, and smaller stomach, faster gastric emptying, less first pass metabolism. These are all different elements that we need to consider. So from the surgical point, how does bariatric surgery change how the body handles alcohol, and what consequences does the patient have?
The short answer is that the alcohol that enters your mouth enters the bloodstream, the systemic circulation, a lot more quickly after bariatric surgery. And that is directly related to the fact that the gastrointestinal tract has been altered with bariatric surgery. As you mentioned, the stomach is smaller now, right? And also, very often with procedures like gastric bypass or the duodenal switch, there is rerouting of the intestine, which will allow for the alcohol to get into the bloodstream a lot more quickly. So what happens with that? Well, a very small amount of alcohol that prior to bariatric surgery a person was able to tolerate without any problem, now that can enter the bloodstream a lot more quickly. Its effect is more intense, and it stays in the bloodstream a lot longer. right? What does that mean? Well, the person will become intoxicated a lot more quickly. The person will stay intoxicated a lot longer, right? Which means that a small amount of alcohol that you thought would have no consequences now after bariatric surgery, that same amount of alcohol may be above the drinking and driving limit. So you could lose your license essentially for a tiny bit of alcohol because the alcohol is entering the bloodstream and staying in the bloodstream a lot more quickly. It impairs judgment, right? If your judgment is impaired and you've had bariatric surgery, it means you're going to forget all the rules you've been told about what to eat, how to eat, and how to live, right? So you could put yourself in a lot more danger, essentially. And then there are far serious consequences, Kemal, and that is the fact that you can overburden the liver with alcohol a lot more quickly and with a lot less alcohol now, creating a situation where you could damage the liver. You could go into a liver failure, essentially, if you continue drinking. So alcohol has some serious changes in the way it's handled in the body after bariatric surgery, and patients who had bariatric surgery need to be very mindful of that, meaning that now they cannot drink the same level that they did before. A very small amount of alcohol will have a much, much more serious effect on them.